you.
Good morning, everyone. It's my pleasure to introduce my dear friend and colleague, Dr. Karen Teufert. She completed her medical school and otolaryngology residency in Brazil and is board certified in otolaryngology in Brazil. She came to America in 1999 to study at the House Ear Institute with Antonio de la Cruz and others, and ended up getting married and having kids and staying in America. She still to this day is doing research with individuals from the House Ear Institute and others, and including myself. We've done some papers together. I met Karen when she was a research scholar at the House Ear Institute, and when I started to do research there as a resident. So I've known her for about 17 years, and she's a wonderful and intelligent, great person, a dear friend of mine. So Karen is going to talk with us about surgical treatment of vertigo, outcomes, and predictive factors today. And I'll let her have the floor.
Thank you so much. Good morning, everyone. Such a pleasure. I want to thank Joni and Dr. Kang for inviting me. And I wanted to dedicate this to Dr. De La Cruz. He was first and foremost my mentor, but my friend. And, you know, he passed away too young and too early. But I want to dedicate this to him. And this surgical treatment of vertigo was sort of more of a generic title, but this was based on 3 papers that we worked on, Dr. De La Cruz and also Karen Berliner, also a dear friend. We worked and published and presented at national meetings, American Academy. The first one was the American Academy. The second was, they're both COSM. I think it was Neurotology Society and Otological Society, but they were presented at national meetings. And we started with the very first one. So this is the generic title, Surgical Treatment of Vertigo Outcomes and Predictive Factors. But I am going to, oh, there you go. First, there are no disclosures. The first one was entitled Improvement After Surgical Treatment of Vertigo Characteristics and Time Course. And I'm just tying myself here so I don't go over. So this was based on a questionnaire that was sent to patients. And the premise was that peripheral vertigo can decrease the quality of life in patients. So we decided to look at assessment of characteristics and timing of post-surgical symptom improvement that can provide a valuable tool for counseling patients about what to expect following surgery for vertigo. So the objective was to have a tool to counsel patients and tell them what it is that they can expect after surgery. The frequency and prevalence of procedures type was for 3,637 surgeries for vertigo over 30 years. And we wanted to assess frequency, severity, interference, and amount of disability for vertigo imbalance, and describe post-operative time course of improvement. We sent a questionnaire to up to 75 patients for each major procedure type. And then we divided between these 2 time frames for 2012, 2023 for frequent procedures, and 1994 to 2024 for less frequent procedures. So these papers were published a while ago, but I was talking to Dr. Doherty and by email Dr. Kang as to what present, and they thought this would be a nice topic, but they were presented back, you know, in 2006 and then 7. All right, now for the methods, the procedures that we looked at were endolimphatic sac shunt, the vestibular nerve sections, which were translabyrinthine, retrolabyrinthine, retrosigmoid, and middle fossa, and labyrinthectomy. And then for the purpose of the study, we grouped them into endolymphatic sac shunt, VNS, or labyrinthectomy. Now, even though the objective of the paper is not to talk about surgical procedures per se, I just thought it would be fun to share some of these images. You probably recognize some of them. They come from otologic surgery, Dr. Brackman. I have the books here, Brackman, Shelton, and Arriaga. I have 3 of them, and I think these are actually from the 2nd edition. There's some small variations, but not a lot. But I just thought it would be fun, to share if you guys don't mind. So for surgery of the lymphatic sac, We have a beginning of a simple mastoidectomy here. And then we have drilling, exposure of the sigmoid sinus, the endolymphatic sac position, the endolymphatic sac being incised, the dura is decompressed. And here there's a little difference with the newest edition, but it's slightly here. There was a T strutting sac, and the new one, it's the same concept. They just have that, displayed in a different way. The translabyrinthine vestibular neurectomy, opening of the semicircular canal, horizontal, posterior, facial nerve skeletonized, and opening of the vestibule. Here we have the sacu and vestibule facial nerve, the ampulla of the horizontal semicircular canal, the common cross, just something that you guys are used to. Now, skeletonization of the internal auditory canal. And here's when the nerves are exposed, avulsion of here we have the inferior vestibular nerve and the superior vestibular nerve. And if needed, you can cut and send that for pathology review if necessary. And the cochlear nerve is not cut. It's, left intact for future, if need of a cochlear implant or anything like that. For the retrolabyrinthine vestibular neurectomy, here we have just, I love these pictures. It just shows the display anatomical position of the nerves. Again, the sigmoid sinus exposed, the dura is elevated, and the nerves are exposed, and the vestibular nerve is cut. Retrosigmoid, same thing, vestibular nerve cut. And then here, middle fossa, and I didn't show the previous steps, just went straight to the avulsion of the nerve. And here we see Scarpa's ganglia. Now, transcanal labyrinthectomy, we didn't really look at transcanal in this study, but I'm just going to show you the pictures here anyway. All right, so let's take a look at the results. So this is study number 1, right? So we divided the time frame by decades: 74 to 83, 84 to 93, and 94 to 2004. You can see that there was a trend for endolymphatic sac to be less prevalent in the last 10 years, and for the vestibular nerve section to be more prevalent in the last 10 years. And that was really more a surgeon preference. I remember us discussing that. There was not really a particular reason for that. The questionnaires were completed by 28 endolymphatic sac patients, 54 vestibular nerve section, and 14 labyrinthectomies. When we look at patient characteristics, age of surgery, they tended to be a little older, as you can see here, for a labyrinthectomy, and that was actually statistically significant. And age of study was the same thing. See here the p-value. When we look at sex female versus male and Meniere's, the majority of the shunt patients were Meniere's disease and also in VNS patients. And the sex distribution was actually more in females versus males for ES, but it seems pretty even for the other ones. Now this, we have in the papers, I was actually going over them yesterday. It's a very nice read, but here we had numbers, we have tables, but I decided just to make it a little simpler. And we're already looking at results. When we look at significant improvement from before to after surgery, and this is, I'm gonna see if I can show here. 10. It's going to be a trend for this paper and the next 2 papers. You're going to see that in vertigo, frequency, severity, and interference is pretty much improving across the board. But when we look at imbalance, frequency, severity, interference, we have poorer results for labyrinthectomy patients. And again, you're going to see that it's going to be pretty prevalent. When we look at current vertigo severity, take a look at the pink one, which is the labyrinthectomy, and the other 2 are ES and VNS. So you can see that for vertigo, patients reported nose spinning dizziness. It's a high percentage. and extremely severe or quite severe, it's a low percentage, right? When we look at imbalanced severity, that's a different scenario. We start looking at labyrinthectomy patients, saying, oh, we know they were not reporting not having spitting dizziness as so often, and the cases of extremely severe, quite severe also increasing. So for the mean numbers, that's also an interesting thing to look at. When we look at imbalance, the ES, the endolymphatic sac patients, had a tendency to do better in imbalance than the labyrinthectomy patients. So we're also looking not just as vertigo versus imbalance, but as procedure itself, labyrinthectomy versus shunt and vestibular nerve section. The American Academy Vertigo treatment class A is optimal, but if you combine class A and B, it's acceptable, satisfactory. And when we look at vertigo, you can see that the majority of it fell into class A or class B. Time course resolution as to how often, because patients, will ask, okay, how long is it going to take? That was another reason we wanted to look at this, to give patients more information. This is all based on replies and answers from patients, by the way. So it has to be taken, that has to be taken into account. So the majority resolved either immediately or days to 1 week or 2 to 3 weeks, but some took longer. We're talking about vertigo, but when we look at imbalance, that was not the case. It took longer. Look here, we had, between these three, we had a high number, but wait, let me go back. Yeah, here we have, it seems that it takes longer for imbalance to improve. So conclusions for this part, for this first paper is that vertigo frequency, severity, interference in the American Academy Disability improved in all three groups. Imbalance improved more for ES and VNS. Vertigo resolved immediately or within days to 1 week in the majority, but not all cases. And imbalance average time to improvement was longer. So these are really important. Let's say this 4 here, when talking to a patient, is to let them know that there is improvement of vertigo. And by the way, vertigo and imbalance was still present in all of them, but in terms of improvement, vertigo improved, imbalance improved more in S and VNS, but not as much in labyrinthectomy. The time frame of improvement for vertigo was pretty, not fast, but faster when compared to imbalance. Clinical implications would be for all procedures, vertigo is likely to improve, imbalance may be more of a problem for labyrinthectomy and VNS than ES, and both vertigo and imbalance may not improve immediately after surgery. So that's another good point when counseling patients. And vertigo spells, I added this today, actually was looking at our conclusions. Because a lot of people know vertigo, they talk about vertigo, but what about also, imbalance? So vertigo spells are not the only source of discomfort. And based on that questionnaire, imbalance seems to be a big issue for patients as well, sometimes more so than having a vertigo spell, than being balanced, a lot. So it seems to cause a lot of discomfort for these patients. Now, based on what we saw, the findings of that first paper, we decided to look at transmastoid labyrinthectomy versus translabyrinthine vestibular nerve section. And again, it was the same questionnaire that we used for that first study. We sent to this group of patients because we're interested. Okay, do you cut the nerve or not? So control disabling peripheral vertigo refractory to medical measures when hearing preservation is not an issue. Do we do a transmastoid labyrinthectomy or a translabyrinthine vestibular nerve section? So when it comes to transmastoid labyrinthectomy, you have, these are the things you get. You get complete removal of neuroepithelial tissue. You have incomplete removal of preganglionic tissue. You have regeneration of neuronal, or can have regeneration of neuronal peripheral processes, and possible traumatic neuronal formation. And I just thought this would be fun. These are slides that Dr. De La Cruz let me borrow back then, and a transmastoid approach. When it comes to the translabyrinthine vestibular nerve section, this is what we know we get. It's the gold standard for the nervation procedures. We have removal of all neuroepithelium and the preganglionic section of vestibular nerves, complete removal of vestibular function. And here you have, that's a cadaveric dissection. internal auditory canal exposed with the nerves. So this is the big question. Is sectioning of the vestibular nerve also necessary, despite the adequate removal of all the vestibular neuroepithelium? Some argue that yes, some argue that no. Schutz back then said no, it's not necessary. He thought labyrinthectomy was enough, but his studies were based on animal models, and I had the privilege of doing this study with Dr. Linthicum. Dr. Doherty knows him very well too. He was just amazing. He had all these ideas and all this, always had something interesting for us to talk about. But anyway, Dr. Linthicum thought that that was not the case, that actually humans behave differently than animals when it comes to that question. Objectives for this paper, for this particular study, based on patient ratings, were to determine the difference in outcome between labyrinthectomy and translabyrinthine vestibular nerve section. And we looked at frequency, severity, interference, and amount of disability for vertigo and imbalance before and after surgery, and the post-operative time course of improvement. We used the same questionnaire as the previous study, so some of the language here will be similar, as you see. Procedures were performed from 1990 to 2005. Questionnaires in this case were sent to all 135 patients that fell into those two categories, and they were completed by 25 labyrinthectomy patients and 17 translab vestibular resection patients. Age at surgery was 59, at study 63.5, and time of follow-up 4.5 years. Sex distribution was, quite similar, and Meniere's disease, same. And here we have other conditions that were present as well. Now, remember that slide that I show with that trend? Here you're gonna see, that's why we see that, because the trend is here. When we look at significant improvement from before to after surgery. For vertigo, we see improvement for both labyrinthectomy and translab vestibular nerve section patients. When we look at imbalance, these patients, the labyrinthectomy patients did poor. And we're gonna explore more as to why. When we look at the vertigo treatment, the majority fell within class A and B. So vertigo improves, but imbalance seems to be an issue. As a matter of fact, when we're asking about imbalance change, the questions were got better, or changed, or worse. 46% of the labyrinthectomy patients actually said they got worse, as opposed to 81% who got better in VNS, in translab vestibular nerve section. That's quite, that's quite a difference. Time of course resolution of vertigo, the majority resolved immediately or within days to 1 week or 2 to 3 weeks, but again, longer for imbalance, same as in the previous study. Now let's look at reasons for failure. Age was the number one thing that we looked, because you can see there was a trend of patients being older. So the question was, elderly patients may have increased incidence of postoperative disequilibrium. Labyrinthectomy patients were older, but then when we looked closer at that, there were no significant differences between age of surgery and current dizziness characteristics. So that was not it, right? Reasons for failure in both groups, again, so the questions were concurrent disease in central nervous system or opposite ear, maybe vestibular disease in the opposite ear, non-otologic vertigo, unknown causes, or failure of or poor central nervous system compensation. Dr. Linthicum suggested and published that in labyrinthectomy, surviving neurons from the Scarpa's ganglion may regenerate the peripheral processes, which grows into fibrous tissue in the vestibule. And the regenerating tissue can form a true traumatic neuroma and persisting balance symptoms. This is courtesy of Dr. Linthicum, and it shows a true traumatic neuroma. This was a patient that had persistent dizziness 10 years after surgery, and she had Meniere's, and she had turned out after she passed and her temporal bone was donated that this was the finding. She had a traumatic neuroma. Now this comes from Mounsell, Brackman, and Linthicum, an article published in 1988, why do vestibular destructive procedures sometimes fail. It's a graphic representation as to when you do not cut the nerve, and here you can see a traumatic neuroma being formed. But when you do cut the nerve, you remove corpus ganglion, so that would prevent the formation of that. Same graph we saw before for current vertigo severity. When we look, pink one is labyrinthectomy, and the green one is the vestibular nerve section. Now, look, when looking for vertigo, the majority is saying, yeah, we don't have spinning dizziness, and being extremely severe to it's quite low. But when we look at imbalance severity, again, that trend changes. And we can see that the labyrinthectomy patients are reporting more extremely severe to quite severe. Not a lot are saying they're not unsteady anymore. Interference, same thing. We have a good result for vertigo in both groups. When we look at imbalance, again, the trend is quite different. Conclusions for this part of the study would be that additional section of this vestibular nerve section may make a difference, not in vertigo control per se, but in imbalance symptoms. And patients rate imbalance as important for their quality of life. Like sometimes we focus too much on vertigo, but imbalance is quite important for them too. And the differences between labyrinthectomy and translabyrinthine vestibular section are less pronounced in Meniere's disease. Vertigo frequency, severity, interference, and American Academy Disability rating improved in both groups. Imbalance improved for translabyrinthine vestibular nerve section, but imbalance did not improve and frequently actually got worse after labyrinthectomy. Vertigo resolved immediately or within 2 to 3 weeks in most cases, and imbalance frequently took longer to improve. Now, before I move on, I wanted just to share this real quick. When I presented this paper, remember it was in Chicago and Dr. Doherty was there. She presented to Dr. De La Cruz was helping me with this talk, and he said, in the end, just say, in doubt, cut the nerve. And I'm like, are you sure you want me to say this in a national meeting in front of all these people that, I was like, it's in doubt, you cut the nerve. So I go there and I present, and at the end I go, in doubt, cut the nerve. And I was like ready to be grilled. I'm like, okay. And then somebody gets up and I'm like, okay, I'm ready. And it was Dr. Castor, one of our previous fellows. And then he said, no, I agree. I think we should cut the nerve. And throughout the meeting, the rest of the day, people were coming like, yeah. And I was like, just relieved that, everyone seemed to be in agreement. Now, based on those two studies, we decided to look at prognostic factors. Okay, so what could be things that we can, it's an exploratory study, by the way, the third one, but what could be things that we could use as prognostic factors and to counsel patients? So in this one, we didn't send questionnaires to new patients. We used the questionnaires from the previous studies, but we also included a chart review. We had a data form developed just for the purpose of that and look deeply into, the chart of those patients and find and give us more ideas as far as prognostic factors. So persistent vertigo and disequilibrium can occur after surgery. We already covered that for vertigo, regardless of surgical approach. Possible reasons for failure could be surgical, diagnostic, peripheral versus central dizziness, or pathology. The objective was to explore a number of patients' characteristics in an attempt to find potential prognostic factors for use in surgical indication and preoperative and or immediate post-operative counseling of the patient. Questionnaires from the prior two studies were used, 94 from study 1 and 17 from study number 2. The questionnaires were completed by 111 patients, 27 were for endolymphatic sections, 59 for vestibular nerve sections, and 25 for labyrinthectomies. And by that time, those two papers had already been published. The questionnaire, just covering this, we already went over this, analyzed frequency, severity, and interference for vertigo and imbalance before and after surgery. The American Academy 6-point functional disability scale was used, and the questions for imbalance were got better, no change, or got worse. We did a chart review, as I mentioned, and we looked for symptoms, other medical history, previous treatments, preoperative hearing, ENG, and surgical variables. Now, outcome measures that we use for current status were the American Academy Vertigo Treatment Score and Class, the number of vertigo spells per month, the vertigo severity, the current and change in the American Academy Functional Disability, the frequency of imbalance, the imbalance severity, and change in balance, better, no change, or worse. Patient characteristics, the usual: sex, age at surgery, time to follow up, site of surgery, diagnoses, Meniere's versus other, and hearing. The questionnaire ratings of pre-surgery symptoms, I thought about adding a picture, but it's quite an extensive questionnaire. But these were the things that we were looking at: vertigo spells per month, severity, interference, frequency, interference for vertigo, and for imbalance, frequency, severity, interference in American Academy Functional Disability Scale. The clinical variables from chart review were time from diagnosis to surgery, vertigo as first or one of concurrent first symptoms, other symptoms, number of concurrent first symptoms, duration of first symptoms, and contralateral ear symptoms. We also look at these other variables from the charts: the preoperative ENG, previous surgeries for vertigo, head injury, eye disease, allergy treatment, and other diseases. Procedure, surgeon, anatomical variations, and related to surgery, operative time, and blood loss. Now, age of surgery, and the mean was 52, and at the study 57, time to follow up 4.3 years. The majority of patients were Meniere's disease, as already expected. The majority were actually vestibular nerve section patients, and then we had 24 shunts and 23 labyrinthectomies. Now let's look at the results. When we look at the current status, 25% of patients still said yes to vertigo. They still were saying vertigo is not entirely gone. And when we look at the American Academy Disability scale, 20% said no improvement. So we're still looking, we're still finding, vertigo is still present, imbalance is still present. And when we look at imbalance, saying frequency, almost never or never, only 33% of those said almost never or never. So again, it's a trend. When we look at the clinical characteristics, the duration of first symptoms range vastly from 5 months to 56 years with a mean of 11, and that was actually statistically significant. Now, I know this is very busy table, but we do, I have a nice little, summary, but I wanted to point out, just like here, everything that is highlighted in yellow was significantly, statistically significant. The preoperative PTA was statistically significant. And the summary for that would be: the greater the hearing loss, the poorer the outcome. So that's one thing to keep in mind. A patient, it's not surprising, but it's nice to have that in a study showing that yes, patients with a greater hearing loss will have a poorer outcome, and that translates into vertigo severity, American Academy Vertigo Score, American Academy Vertigo Score, and American Academy Vertigo Class. In our study, those were the findings. Still looking at outcome measures. The three things that were pretty consistent were before imbalance frequency, before American Academy Disability, and then we're going to look at the third one. So you looked at across the board for all the prognostic, for all the outcome measures across the board, they were statistically significant, meaning that the greater the preoperative frequency of imbalance and the greater the American Academy Function Disability Scale, the poorer the outcomes across all measures. And I'll mention later, but it would be, when we're doing this study, we're talking about the possibility of using actually the American Academy Function Disability Scale to, before surgery and to counsel those patients. I would be curious to know if that's, the opinion of everyone, or, what you guys think about that. And duration of first symptoms. So when I was saying that three things were pretty predictive, were the before surgery imbalance frequency, before surgery American Academy Disability, and duration of first symptom. So the greater the duration of the first symptom, the better the outcomes, because like right here, we have a little note saying higher score equals better. So interesting to keep in mind, again, greater preoperative imbalance, greater American Academy Disability, poor outcomes, but greater duration of first symptom, better outcomes. Now, when we look at improvement in imbalance and the prognostic factors, imbalance got better in 77% of patients with Meniere's disease, and as expected for ES and VNS, and patients with no other significant disease, patients with no allergy, which is interesting. When we look at contralateral tinnitus, patients that said, no, we don't have contralateral tinnitus, did better. Patients that did have contralateral tinnitus did not do as well. When we look at the class A and B for vertigo, imbalance being not severe, having none, and improvement in disability rating and improvement in imbalance. 25% of patients in average surgical groups still experience attacks of vertigo, and 15% had a class C or poor American Academy of Vertigo result. When we look at reasons for persistent vertigo and or imbalance, questions are, like we stated in the very beginning of this last part here, disease in the central nervous system or opposite ear, maybe non-otologic or non-vertigo, maybe failure of or poor central nervous system compensation, incomplete nerve section, traumatic neuroma, again, that picture that Dr. Linthicum provided. Age was a question. Elderly patients maybe will have an increased incidence of postoperative disequilibrium, but as we already noticed, there was no significant relationship between age at surgery and current dizziness. Now, when we look at the summary of our findings, worse postoperative ratings of vertigo and imbalance in patients with worse preoperative American Academy Disability rating. So again, should we use the American Academy Function Disability Scale in preoperative evaluation? Higher preoperative frequency of imbalance and longer duration from beginning of symptoms to surgery. Improvement in imbalance, we notice in Meniere's disease diagnosis, no other significant disease, and no allergy or previous allergy treatment. So in conclusion, persistent vertigo and imbalance can occur regardless of a surgical approach. Vertigo gets better, and imbalance, will get better. Labyrinthectomy is the one that we're focusing on here, but they can still be present. Worse American Academy preoperative functional disability equals a poor outcome. Other factors include duration of disease, contralateral tinnitus and allergy, and frequency and severity of preoperative vertigo is not predictive. Dr. De La Cruz, again, wanted to dedicate this to him, and he was an amazing a teacher. I remember sitting next to him in surgery, and it always amazed me that he was so humble and would ask for our opinion, and I would feel like, why are you asking for my opinion? But that's who he was. He always strived to be the best he could as a person, as a teacher, and as a physician. His patients always came number one. He would get up at 4 a.m. every day, and he would send me emails at 4 a.m. I'm like, why do you get up at 4 a.m? He goes, well, because when I go to meetings, I travel all over the world. I am ready. I am not jet lagged. And I go, that's a very good approach. But he was an amazing teacher, and I had the opportunity to collaborate with him on publications of papers and book chapters. These are, first of all, thank you. And these are pictures from Karen Berliner's brother. He is loves to take pictures of birds. He lives in Oregon, and Karen sent me this picture, and another one I'm going to show to you yesterday. She thought it would be interesting. They're very recent. This is a hawk, and this is a hummingbird, and she thought it would be a good way to introduce this if only all could have this kind of balance, because the hummingbirds are pretty amazing with what they can do. But anyway, I thank you so much again for allowing me to be here this morning. I was telling Kim and Dr. Doherty, USC has a very special place in my heart. And you are, I've been taking part of this meetings for the past months, and I'm impressed with the quality of the talks and the residents and everyone, and very talented. You're all very talented, and appreciate you all. Thank you so much.
Karen, that was a great talk. This is Courtney Volker here.
Hi.
Hi, how are you?
I am very good. Thank you.
Great talk. And, for all the neurotologists here, vertigo and imbalance are such a part of our practice and trying to help the suffering population of patients. I find in my own practice there's a big number of a large number of patients that have an overlap of vestibular migraine and Meniere's disease, and I wonder if in those sort of residual vertigo imbalance groups, how many of those had residual migraine symptoms?
Yeah. Yeah, I agree with you. And one of the things, also a question that was raised, and good point. And what we, like in the end of the 3 studies, we got to the conclusion they're exploratory studies. So these are supposed to be, they were, the information was taken from questionnaires, patients, and some of them were not very consistent. But one of the things that we're also pondering was, a lot of these patients, sometimes with Meniere's disease, sometimes it burns itself out, right? Meniere's is known for that. So, and also sometimes they might already have been developing Meniere's on the contralateral ear. So there are a bunch of variables that could account for that, as in one of the ones you just mentioned. So there is more room actually for more studies and continue investigating. We kind of ended on the series of 3 papers, but we wanted to actually have pursued the Dr. De La Cruz passed, not too long after, unfortunately, but it's something that I'm still interested in pursuing. So yeah, that's a very good point, and something that I would definitely keep in mind if we do any future, or if you guys decide to do any future studies on the subject.
Thank you.
You're very welcome.
Thanks so much, Karen. That was such a great talk. Sorry, my dog was like trying to bite my ankles. I really appreciated the how you linked like the prognostic factors with the surgical outcomes. That really helps us when we're talking to patients about these kind of options.
Yeah.
But, yeah.
Do you, Dr. Doherty, do you guys, is the American Academy of Disability Scale used at all at USC or in your practice, or do you guys?
I mean, it's mainly for publications,
Maybe.
for studies. Yeah, I mean, we don't use it in practice.
Okay, because that's something we were pondering back then. If it would be interesting to kind of use that and see where the patients are at and have a better, idea. Because it would be nice, I think, to sort of be able to. Of course, it's not an exact science, but to kind of predict. That was the whole objective, and where they would be at after surgery, and or already be able to tell them this is where we're at and this is what we can expect. And because I think it must be pretty frustrating for someone to go into a surgical procedure and expect for their problems to be solved, and maybe it got even worse,
Right, I know, that's true. I mean, patients want 100% cure most of the time. It seems like that's what they expect. But yeah, you really do have to kind of lower their expectations if you're going to go with the surgical route. I mean, I normally, like Dr. Volker, I sort of consider Meniere's on a scale, like on a spectrum with vestibular migraine. And So I normally do try to treat them for migraine, and sometimes that improves the Meniere's symptoms, but not always. And so, you know, I have a number of patients that I end up taking to surgery because they fail, you know,
When
with
they
the,
have Meniere's migraine, I mean, I'm sorry, when they have it, when they have migraine and you treat it and then you go for surgery, do you get improvement?
I haven't really done it enough to actually like look at that objectively. So that's something that should be looked at too, is to,
Yeah.
you know, compare with the ones that do have migraine symptoms that end up having surgery with those that don't have any migraine type of symptoms. Like I have, you know, a couple of patients who are just strictly the Meniere's symptoms, and they don't report any kind of like photophobia or headache or scintillations, visual changes, or anything like that.
Yeah, that would be very interesting. Yeah, we did not look at migraine. That would have been an interesting, you know, thing to have, but we didn't do that. But yeah, that would be something really interesting for a project.
Yeah, absolutely. Yeah, we have a lot of vestibular migraine patients, that's for sure.
And the question, do you guys cut the nerve?
Well, when we get to that point, yeah, if we're gonna do vestibular neurectomy, yeah. You mean just with labyrinthectomy, cut the nerve?
Yeah, labyrinthectomy versus like when you do a transmastoid labyrinthectomy versus transmastoid, like translabyrinthine vestibular nerve resection. Do you cut the nerve or not?
I don't with the labyrinthectomy. I haven't, but it makes sense, like you were saying. I mean, definitely that does make sense to do it. I just haven't ever opened up the internal auditory canal.
Yeah, yeah. A lot of people don't want to do that. That was one thing that a lot of people are. They're just hesitant to have to do that because, you know, you're opening dura and all that. But
yeah,
that's why at that meeting after de la Cruz, when he said, well, at the end said, in doubt cut the nerve, and I'm like, okay. But yes, Dr. Linthicum, yeah, that's a different, that's his, I just showed the picture of the traumatic neuroma, but I did a study with Dr. Linthicum and we're looking deeper into that, and humans behave different than the animals. And Schutnik had said, no, labyrinthectomy is enough, but he was saying that based on animal models. But based on humans, it behaves a little differently. The regeneration happens in humans more often than it does in his studies were based like on animals. So he was not seeing that.
Yeah.
But yeah, you're right. I mean, I do see the point. Like if you're doing just a labyrinthectomy, is a much less, I mean, it's surgery, it's invasive, but it's less invasive than having to open internal auditory canal and all that.
Right. You can do it as an outpatient procedure.
Yeah, exactly. And I don't know, in all honesty, I mean, this was like, it's an exploratory study. It's based on questionnaires, but the difference between labyrinthectomy and translab nerve section was pretty striking. When it came to imbalance, vertigo is the same. So if you're looking at, okay, what am I'm treating vertigo. Okay, then you're gonna get a good result for both. But imbalance stayed. And also based on the questionnaire, that those patients were pretty affected because we went over like, how much does it interfere with your daily activities? It was very detailed when it came to finding out how much they were affected, and imbalance affected them quite a lot. So it's one thing to consider.
Yeah. Does anyone else have any questions for Karen?
I have a question.
That's Seiji Shibata, Dr. Shibata.
Hello.
Hi, nice to meet
Hi.
you. I'm Seiji. I'm one of the newer neurotologists here.
Nice
I just have yeah, nice to meet you. Great talk. What do you have of all your patients? How many of those went on to like develop bilateral Meniere's disease?
Oh, I don't have that. Yeah,
you don't have that.
I don't.
Okay.
But that's again, that's another very interesting. But I don't have that. It was there was a consideration like in the paper that we have to consider that that's the case, but we did not look at that.
Right.
But that's another thing that would be interesting to look at.
Yeah, because that's one of the other reasons why sometimes I'm a little bit hesitant to cut the nerve, especially in younger people. you know, that there might be a possibility that they have like bilateral Meniere's disease in the future.
Uh-huh.
And I think in one gal that I did recently, I did an endolymphatic sac surgery, and then I also put in a cochlear implant at the same time. And my thought was, rather than doing like a labyrinthectomy, vestibulorectomy, I would just come back and do like gentamicin injection if she develops vertigo or imbalance. So, you know, I wonder if just doing a translabyrinthine approach and just taking out the neuroepithelium and then coming back later if they developed imbalance again with gentamicin injection to destroy some of the regenerating nerves might be an option.
Yeah, no, I agree with you. As far as removing the neuroepithelium, what Dr. Linthicum observed is that there's still regeneration. That was just one picture of a patient, but he had more. So that was what he proposed, that just removing, you're not, I mean, you're still leaving scarpus ganglion behind. And I don't know if you remember the little graph that I showed. So what he said and found was that even if you just remove the neuroepithelium, even if you do that, you're still leaving, you know, the scarpus ganglion behind, and that could lead to regeneration and formation of traumatic neuroma. That could be the cause of imbalance in these patients after surgery. But yes, I mean, there are so many factors you should take into account: a younger patient, possibility of contralateral Meniere's disease, going from a less invasive approach to a more. I agree with you, and I think it's also a personal, like surgeons will have their personal, like the way of their preference.
Biases, yeah.
Dr. De La Cruz is just, I mean, that was his suggestion.
Is the is the regeneration the neuroepithelia, like hair cells regenerating, or what exactly is it? The nerve fibers that are coming back?
Yeah, as far as I remember on Dr. Linthicum, so I have the papers here, but I'm not gonna waste your time too. But what he was saying is that if you leave scarpus ganglion behind, they have, and Dr. Doherty can probably help me answer that too. If you leave scarpus ganglion behind, that will lead. They still have the capability to regenerate. Regenerate and go into that patient actually, that picture here, let me see if you see.
Right.
That traumatic neuroma that I showed, she had it was in the stapes foot plate. The traumatic neuroma was a bud in the stapes foot plate, and she had been dizzy for 10 years after a labyrinthectomy. So what
it was only found in the temporal bone, so she said. So
okay.
she suffered, she never got cured because
she never got cured. So
but gentamicin might have helped, you know?
Yeah, that's true.
Seiji, I wanted to just add before, we still have some time, but John House and I did that study on how many patients convert to bilateral Meniere's.
Oh, really? Oh, cool.
Yeah. It was published like in, I don't know, 2005, I think, or it was pretty long ago, but or maybe 2006, but it was like all their patients at House, and that we found it was about the 17% incidence of converting to bilateral. So pretty low. I mean, fairly low.
Yeah. Okay. Great.
But also that back then we didn't consider vestibular migraine. Like it was only like Meniere's or not Meniere's, you know. It was I think that was before vestibular migraine was even like a recognized entity. Right. So, you know, it probably something like that should be repeated and separate out the groups.
Exactly. Thank you.
Oh, and I have here, do you have a few minutes? Is that okay?
Yeah, we have 10 more minutes before
I found here so I'm just going to read it real quick here actually that's from the transmastoid labyrinthectomy versus translab paper. So Linthicum Let's see if I go back to it real quick. 6. So I'm just going to read it to you. After labyrinthectomy, some surviving neurons from Scarpa's ganglion may regenerate the peripheral process, which grows into fibrous tissue in the vestibule and can form a true traumatic neuroma. Although whether it always does or so is not known. And then Linthicum and Monsell concluded that any trauma to the neuroepithelium may induce anomalous regeneration of neurons that cannot be prevented by thorough ablation of neuroepithelium. Noting that a traumatic neuroma may occur on a nerve that is interrupted this to the cell body, and if on a sensory nerve can be symptomatic, such as in the example of a phantom pain of amputees. And he thinks that if a traumatic neuroma occurs on a segment of the vestibular nerve, vertigo can occur.
I see.
So that answers that, yeah, what you're saying. So that was his, and you know, and then he started seeing that in temporal bones of patients who donated their bones after dying.
Okay. Thank you.
You're welcome.
Yeah. Great talk.
Thank you so much.
All right, well, thank you so much. If no one has any more questions, we'll move on to the second year presentations. But thank you so much, Dr. Teufert. We really appreciate it.
Thank you.
Thank you so much, Karen. Really great talk. It was
Thank
really
you.
great to
Thank
see
you,
you.
Dr. Doherty. Thanks for inviting me.
Of course. Take care. Talk soon.
Okay.